There we go. Good morning, everyone. We're going to go ahead and get started. 6:30 for grand rounds. Today we have Dr. Pillarisetty, and Dr. Shan will do our introduction.
Thanks so much, Colette. Good morning, everyone. I know everyone in the room, but for those online, my name is Jonathan Shaman. I'm the chief of the section of HPV surgery here at UW. It's my distinct pleasure to introduce today's grand round speaker, a man that for many of us here today, I suspect needs no introduction. Dr. Venu Pillarisetty is professor of surgery here at the University of Washington and associate medical director of surgical oncology at both the Fred Hutch Cancer Center and the University of Washington Medical Center. A graduate of Columbia University College of Physicians and Surgeons. He completed his surgical training at the University of Massachusetts, and then went on to surgical oncology fellowship at Memorial Sloan Kettering Cancer Center, where he spent 3 formative years in research in the lab of Ron DiMatteo that would set the trajectory for his research career. And that career has been truly remarkable. Dr. Pillarisetty has built one of the most productive translational research programs within the School of Medicine and in the country, pioneering research on the tumor immune microenvironment. He is principal investigator of the Time Lab, collaborating with researchers around the country on multiple disease types ranging from fibrolamellar carcinoma to pancreas cancer. He is funded by the NIH, Department of Defense, Cancer Research Institute, PanCan, many more, and his bibliography spans more than 100 peer-reviewed publications. Venu brings the same rigor and thoughtfulness to his clinical practice, providing care for complex pancreas pathologies for patients across the Pacific Northwest. Many of us in this room, myself included, have benefited from his guidance over the nearly 2 decades here at UW, where he has mentored dozens of students, residents, and fellows, both in the lab and in the OR. We are truly lucky to have him here in our department, and I'm lucky to call him partner. Please welcome Venu Pillarisetty.
Thank you, Dr. Sham. That was really kind, and you took away some of the things I was going to talk about because at least I can go quicker on my own CV. But the topic is bench to bedside and everything in between. After when you've been in practice for like 17 years, you have a lot of different things you could talk about. And of course, I'm going to talk a little bit skewed towards the clinical side of things, but I think the big point for me in talking about this, and I think really important for residents who are thinking about it, is like, if you're going to be a surgeon scientist, you're always just trying to be a surgeon scientist because it's really, you're trying to do a lot of things that are difficult, just like we're trying to be good surgeons and trying to take good care of patients. So I think approaching it in that way is the way to probably kind of be get the most you can done, but it's a hard process. Disclosures, I have some research funding that comes to UW, one company. We're not talking about anything related to that. I found out that the CME people don't really like comedy, but I was going to put a disclosure here, which is that I failed immunology in medical school. And I had to take a makeup test, which I also failed, an oral exam. I spent all spring break studying for it in second year of med school, and they failed me on that. And only towards the end of second year did the head of the entire second year curriculum call me and say, I talked to these people and told them to leave you alone. So it's just kind of an interesting point. And my worst rotation grades in third year were neurology and yes, surgery. So I'm just trying to do this. Objectives here, you have to do this for CME, but really I'm just talking about, kind of why would you want to be a surgeon scientist? Some of the risks of pancreatic surgery and things that we've done to try to reduce those. And then, why immunotherapy hasn't worked in pancreatic cancer and why I think it is going to be working in the future. Thought I'd start with some definitions. I looked at Oxford English Dictionary. So a surgeon is one who practices the art of healing by manual operation, a practitioner who treats wounds, fractures, and other conditions by surgical means. A scientist is a person who conducts scientific research or investigation. I love these circular definitions. An expert in or student of science, especially one or more of the natural or physical sciences. And then you type in surgeon scientist and OED has nothing. So I'm just going to say it's a surgeon who uses scientific technique to try to answer questions important for the care of their patients, because that's kind of what a lot of us are trying to do. American College of Surgeons thinks this is important, which is really exciting. This just came up recently as I was searching for something, and there is a plan to have a surgeon scientist pathway, training pathway for residency, and there's going to be a pilot program that different departments around the country can sign up to be part of, where residents would match directly into this surgeon scientist pathway that goes beyond our model that's always been, you do your 2 or 3 years of clinical work, and then you move into your research time, and then you move back into clinical. It's trying to integrate it across the 7 years so that it's a little bit more of, kind of like long-term process to try to build people into successful scientists. Um, the I'm not going to spend a lot of time talking about the obvious headwinds that are facing us in so many realms, but particularly in science. Getting NIH grants was always difficult. I think there was a period where it wasn't crazy difficult. Now it's gotten to apparently like fourth percentile of grants are the ones that might be getting funded, and even if they do. But I'm hoping that this is something that will change over time. So I think that there's a future in this, and that we will revive from the current situation. So I would invite any of the medical students or people who are interested in this kind of thing to be thinking about this. And hopefully our department will look at this as a viable option for residency. So my pathway, Dr. Sham already mentioned, but I did my first couple of years at University of Massachusetts. I pretty much knew I wanted to do oncology, and I knew I wanted to go in Sloan Kettering for research, partly because I wanted to go there, partly because I really didn't want to spend my entire time in Worcester, Massachusetts, which, no offense to anyone, but I didn't love it. So I went for 2 years to be in Ron DiMatteo's lab. I and this is important for people who are going to choose where they're going to do their research. I met a bunch of people. One of my mentors knew Murray Brennan, and I got set up to meet so many different people when I went to Memorial. And Ron was like a second or third year attending. And when I met him, it's like, this is the person I want to work with. There were other big labs where I could have just stepped into some big machine. Instead, I went to some lab of somebody I didn't really know, but or wasn't really well known at the time. I thought, okay, this person is going to mentor me well and is doing good science. So I made that decision. I think it was actually a really good decision. Ron is a pretty major person in the field of academic surgery, and a great scientist and a great surgeon. So that 2 years turned into 3 years just because I couldn't finish everything I wanted to finish. And luckily my program supported that. Went back to UMass, finished residency, went back for fellowship, and then have been here for so much longer than all of that time. So again, when you're a resident or a medical student, it looks like a lot of time, but actually the time after that is so much more, and it goes by like that. When I got here, my son was a year and a half old, and he's about to go to college, which is extremely surprising that he's about to go to college. And he's supposedly graduating. So what they say he's graduating. I don't know how he's graduating, considering how little time he spent in school this year. But anyway, that part is the time of trying to be a surgeon scientist. So I thought I would write a quarter century, but that made me feel really too old. So I went with 25 years of working on that. I'm going to talk about pancreatic cancer as the main thing, the main disease, because that's what I take care of the most. I've had a lot of experiences that made me interested in that. One of the formative ones was when I was a second year medical student. One of my best friends from high school, because I grew up in New York, his mother died of pancreatic cancer during that time. And I kind of saw this process, and she was like 50 years old. It was just awful. And I think that kind of embedded in me as something that was, kind of back there. And somehow I wound up in it. And obviously, like everyone else here, I like difficult problems. And I saw this as also something to work on clinically as a difficult problem, but also from a research standpoint, it was something that I didn't really think was going to be solved early in my career, and that I would be completely out of business. So I think as you think for the trainees again, as you think about what you want to go into, pick the patient population you like, pick problems that are really meaningful to you, and that's going to drive you to do something interesting. So pancreatic cancer, it's everyone knows it's a very bad disease, and long-term survival is still less than 10%. Early stage disease, doesn't really exist, even though we call it early stage disease. So most people who have pancreatic cancer, regardless of the stage, are going to have it come back, and most of them are going to die of that disease. And then pancreatic surgery is high risk. Some people focus in it, do it better, but there's still a lot of complications. And it's not something that we can just say, oh, yeah, you'll be fine. I don't tell patients in clinic, oh, we're going for curative treatment, but we do say we're going to try to help them and give them a little bit of useful time. And then in the context of immunology, which of course I've long believed in despite my failing at med school, um, immunotherapy has been an incredible success over the last decade plus, right? A little more than that. But immune checkpoint inhibitors haven't worked so far very well in pancreatic cancer. I think there's a lot of things that are relevant to that. Related to this idea of early stage disease, if you look at these curves, this was a paper from almost 2 decades ago. This is a very long time frame. This is real survival out to like 10 years. You can see how fast this drops off. This is more recent. So this was comparing modified FOLFIRINOX to gemcitabine. This is only out to 5 years here. So you can see this is like the best case scenario where patients are surviving like maybe 50% 5-year survival. In the real world, we don't really see this very often. So it's highly selected in a clinical trial. And then this is a trial that just came out recently comparing FOLFIRINOX to a different 4-drug chemotherapy. FOLFIRINOX is 3 drugs. This is PAX-G. It's like 4 drugs. And there was an improvement over the FOLFIRINOX, but then the FOLFIRINOX looks worse than it did in the other trial. So, kind of marginal improvements, but this is like the best you're going to get, the best set of populations. So problems in general of cancer treatments are that a lot of it is based on animal models, and a lot of what works in mice, it's really kind of not that hard to cure mice of cancer. When I was a research fellow in Ron's lab, we gave cancer, we cured cancer in mice, and it wasn't that hard to do necessarily. So there are a lot of cancers like pancreatic cancer where true cures are really kind of rare. There's a lot of hurdles to getting clinical trials to actually happen. And I'm going to talk about one of those situations. Predicting who's going to respond is really difficult. So if a blockbuster drug might lead to a 20%, increase in survival, but think of all the other people who weren't part of that. And maybe another drug would have had 10% increase in survival. Well, those are individual people. How do you know which ones those are, and how do you give the right drug to the right person? So that's really important. And then, as I mentioned, immunotherapy has left a lot of people behind. So I'm going to start with a patient story. So HJS, a 66-year-old man who has a history of excessive donut and beer consumption. He presented with yellow skin, was found to have a pancreatic head mass consistent with pancreatic ductal adenocarcinoma, PDAC, pancreatic cancer. I've blurred out his eyes so you can't figure out who this is. And we talked about this person in pancreatic cancer clinic, and you can see there's a mass in the head of the pancreas. And as we talked about it, we decided to go ahead and start with surgery. So he had an uneventful Whipple, and uneventful meaning things went fine in the operating room, but 4 days later, presented with very sick, right? And ultimately was found to have a leak from the pancreas, from the pancreatic anastomosis. There's a bunch of abscess fluid here. Basically needed another drain put in. Really just took weeks to recover, was in the hospital for a long time, got 6 months of FOLFIRINOX chemotherapy eventually. And then 2 years later, had cancer come back, was found in the liver, got more chemotherapy, was really tortured with all this treatment, and then died of it. So, nothing funny about it, right? But like something to remember, like this is where we go, this is what patients go through. We do a lot of treatment. It doesn't always help, and sometimes it can hurt them. So what I would say is, can we imagine a better outcome for Mr. S? And I think we can, right? The big things that we're trying to do that I'm going to talk about is prevent the leak. So that's one thing. And then prevent the recurrence. And it turns out that if you have a leak after pancreatic surgery, pancreatic cancer, you actually have worse survival. there's probably a lot of things that happen in that time. Anybody who gets really sick after surgery probably has an increased risk of their cancer coming back because, as I mentioned, the immune system must be important. So I'm going to start with that. So postoperative pancreatic fistula, it's basically when you have either, if you have a distal pancreatectomy and the pancreas has been cut, you have pancreatic enzymes leaking out into the abdomen. If you did a Whipple, you have an anastomosis, and those pancreatic enzymes and the fluid from the from the jejunum will leak out. There's a little difference in how important those leaks out are and how bad they are. If you have a leak from the cut edge of a pancreas, you have inactive enzymes mostly, or at least the proteolytic enzymes aren't activated. So lipase and amylase work, but then of course there's chymotrypsinogen and trypsinogen, pepsinogen. All these things are inactive form. They need to be activated by enterokinase that cleaves them into the active form. So when you have a Whipple, they get activated, and then you get really bad leaks that can eat through all sorts of structures and cause bleeding, cause a lot of problems. Even though people have worked to improve techniques, they're actually pretty common in high volume institutions as well. And, there is some variation surgeon to surgeon, but in the end, they still do happen. There's a grading system for them that kind of follows from like this low grade, you check the drain amylase, there's some amylase in it. It doesn't really mean anything. You leave the drain in for an extra week, all the way down to organ failure, death side of things. So it's pretty real. It's a little in this room, a little bit dark up there, but basically that's just showing some jejunum here, and this is the cut edge of the pancreas. And all I'm showing there is just there's a lot of technical ways of trying to reduce a pancreatic leak. I started using pledgets when the pancreas is soft. I think it helps. Very hard to prove those kinds of things, but we've seen lower leak rates doing that. If you have less blood loss, interestingly, there's a lower leak rate. Patients are more stable. Who knows exactly what that relates to? And then there's a lot of attempts at pharmacologic um, reduction of pancreatic leak. So part of it is that physical, maybe anastomosis leak, but part of it is the enzymes themselves. So in general, if somebody has a pancreas that's not super functional, your risk of leak is quite a bit lower because the enzymes aren't coming out and they're not digesting through the other tissue. The the main drugs that have been used to try to reduce pancreatic leak are somatostatin analogs. When you use a somatostatin analog, your one of the side effects of those drugs is reduction of pancreatic enzymatic secretion. So people have tried octreotide, which is a very short half-life drug, so a little bit difficult, and you have to give it 3 times a day. And once you stop giving it, it's not going to have that effect. There is pasireotide, which I'm going to talk about in a moment, and then lanreotide, which we'll talk a little bit about after. So as I mentioned, they've been used quite a bit. And there's a lot of text here. You don't really need to think about that too much. But this trial at Memorial Sloan Kettering that started right after I finished fellowship was comparing pasireotide to a control placebo. And they were able to enroll over 200 patients per arm. These are patients getting Whipples or distal pancreatectomies. And they were able to find that if they compared the pasireotide to the placebo, the total combined leak abscess rate was about halved. And it was true for both Whipples and even more so for distal pancreatectomy. Subsequent studies have questioned it. This was a single arm study, and the problem with that drug is it really made people sick. And I've heard from people who were in training at the time when the study was running that even though it was double blinded, they knew who got the pasireotide because these patients were like really sick. And the problem is that you have to be giving that drug twice a day. And of course, it's super expensive, but that doesn't change with other things. So this was coming out around the time that I had already kind of gotten into practice and had plenty of pancreatic leaks by that point. We talked about whether we could even get this drug approved here. The pharmacy committee was like, no, it's too expensive. The data is not strong enough. And it happened to be that I got one of these emails that like everybody gets all the time from various different companies. I was like, what is a medical science liaison? When I got the email from this person saying, we have this drug lanreotide, we're looking to do studies. So I had to look it up and figure out like what is lanreotide. So it is an injectable somatostatin analog, and it was FDA approved to treat acromegaly and neuroendocrine tumors. So if somebody has advanced gastroenteropancreatic neuroendocrine tumors that have spread, you can give that drug and generally keep the tumor from growing. So it's very specific for somatostatin receptors 2 and 5, and that's actually really important because pasireotide was super well binding to like every somatostatin receptor, whereas this one is specifically 2 and 5, which tend to be the ones that are more important for the pancreas secretion aspect of things. And what was really nice about it is that it's like a gel formulation that lasts a really long time. So you get really rapid onset, supposed to reach close to blood levels in about 7 hours, but it's got a half-life of about 3 weeks. So I thought maybe a single dose of this drug given right before surgery, maybe that would reduce the risk of pancreatic fistula. And it turned out like there's a lot of conversations. And as you go through to get to a trial, you read about the trial. Once you've done a trial, you truly appreciate the number of years that whoever got that trial to happen, how much negotiation, how many conversations, how many things they had to learn along the way. And apparently I only got to run this trial because I was like the first person to respond about this, and several other surgeons responded with the same idea like the same day. And it was just that I was the first. So then when Ipsen, the company that wound up that has the drug, they did fund the trial because I submitted this proposal. They said, yeah, a lot of people actually wanted to do this trial. So it was actually a really interesting thing. So the trial wound up being we took patients, single institution. I wanted to do a randomized trial. There wasn't enough um, preliminary data to be able to get the funding to do a multi-center randomized trial. So we did a single arm, single center study where we had patients who were undergoing Whipples or distal pancreatectomies for malignant or pre-malignant disease. And that was really just so that we could exclude patients with pancreatitis. We gave them lanreotide in the preoperative area right before surgery. And then we did standard care afterwards, and we followed them for 60 days. It was pretty much here's the Whipple patients. There were 62 in total, and then distal pancreatectomy, there were 36. Pretty much represents like kind of a typical setup, typical population. Um, and then this is the table with all the results. And in the end, this is the primary outcome, which was, as I mentioned, grade B and C pancreatic fistula, basically bad ones. Somebody had to be treated in some way for this pancreatic fistula or abscess added up. And we had a rate of 8%, which is really low for that. And we compared it to literature and, in general, it's about 20% or more. It can be quite a bit higher. So that was exciting, but it wasn't a randomized trial, so you can't really prove it. So this served ultimately as preliminary data. So this is about, I don't know, 6 years of work to get to preliminary data for the trial that Dr. Sham is running. And quite a few years of making this happen. At some point, I'm sure he'll be talking to you guys about this in great detail, but this is a randomized trial. We were going to do it in Whipples and distal pancreatectomies. A lot of negotiation happens to make things happen. And in the end, it's for distal pancreatectomies where we saw the largest signal and kind of the easiest to control because there's not as much technique and, there's no anastomoses, things like that. Patients are going to get lanreotide, or not gonna, they've been getting, or a placebo, and it's going to be 274 patients in total. They'll have surgery. They're going to have outcomes measures checked, and it was going great, accruing incredibly well, and there was an issue with drug supply, so it's actually been on hold for 5 months, something like that, maybe a little less than that. But hopefully it will get started again, but it was already accruing up to like 15 patients a month. So it was going to get done actually quite a bit earlier than planned. So that's not fully answered, but I think we're going to get there and we'll have something. So when we get back to this question of the better outcome for Mr. S, we talked about preventing the leak. We think that if we prevent a leak, we can help prevent recurrence, but really the crux of my, my career has been trying to figure out how do we really prevent the recurrence? How do we treat the cancer? So as I mentioned, we're wondering, and I've been wondering, can pancreatic cancer respond to immunotherapy? It hasn't really so far. I wanted to just talk a little bit about some of the constructs that people have created to think about the cancers. Of course, everything is a little bit artificial. We don't really have exact cartoons replicating like what's happening, but the concepts I think are important. So if we separate tumors out into a few different types, we can start with like inflamed ones up here. So those are ones that have a lot of immune cells. There's lots of T cells. They're kind of like all over the place. Melanoma is often thought of as like the prototypical one, probably the biggest reason why a lot of the earliest wins for immune checkpoint inhibitor therapy have been in melanoma. You've got these activated T cells that are sitting in the area that probably just need a little bit to overcome the suppression that happens in that environment. There's the immune desert, which is this idea that there's really just very few immune cells. You almost have like immune cells sitting outside, and then you get into the tumor, and there's really not much there. Certainly not a lot of T cells. There might be a bunch of macrophages. And then there's the immune excluded, which is actually it was originally dichotomized and then immune excluded was added because people started realizing there are a lot of tumors where you've got immune cells kind of like all over in the tumor, but they're just a little bit away from the cancer cells. For whatever reason, they're sitting in the scar tissue region of the cancer. So, um, when I first started, I was actually working in mouse models and wanted to learn a bit about what that could show. This is something that's come out a little more recently, but from a group at UPenn where they took the most commonly used pancreatic cancer mouse model that has a KRAS mutation and a P53 mutation. They created cell lines from that autochthonous mouse model. So the mouse is generating these tumors, and then you can make different cell lines. Some of the cell lines had a lot of T cells. Some of the cell lines were low in T cells, and they did a bunch of studies showing kind of some differences between these tumors. And I think I wanted to just point something out that is important when you're looking at the literature. And this is the way they show the figures. They're kind of like on top of each other. This is human versus mouse. And their point was in human tumors, there are some patients tumors, right? Some tumors that have low numbers of CD8 cells and some that have high numbers of CD8 cells. And then in mouse, they found some cell lines that had low and high. But I think it's really important to look at the y-axis and look at those numbers. And here we're talking the low in humans is higher than the high in mouse. And that's a really critical distinction because if you ask the average person who studies pancreatic cancer, they will tell you that there are very few T cells in pancreatic cancer. And it's based on mouse models. This paper just came out within the last month. This is from Max Krummel's group at UCSF. He's done an incredible job categorizing different tumors, looking at the immune microenvironment of a lot of mouse model stuff. It's kind of interesting because most of his work really was in mouse models. But what they did is they looked across all these different tumor types from human and mouse. And the fundamental point is if you compare like the immune cell population, the orange side is the mouse and the bluish side is human. You compare them. They're much lower in mouse. The number of T cells is extremely low in mouse. This is across different tumor types. So this is a fundamental issue in the field in terms of how things are studied, and that you're looking at these mouse models that don't fully reflect the human immune system. I don't think that's really surprising. So we had been studying human pancreatic cancer for a long time. This is a paper we published quite a while ago, and it was in PLOS One, which is fine, but it was really hard to get published because people didn't believe the things that we were showing because it didn't match the mouse. We were studying humans. So they're like, oh, this can't really be right. The point here, and what you're seeing is a pancreatic cancer. These areas are the pancreatic cancer glands. So these are cancer cells. And then these areas that are running between them are the stroma. So that's the fibrous stroma. There's a matrix there. There's a lot of fibroblasts kind of like all over the place here. Um, the story gets much more complicated from 2014 to now as we start to understand it. But the arrows are pointing at T cells, and then the arrowheads are pointing at like myeloid cells, which are like macrophages. And I think what's apparent from this, though, is that these immune cells are mostly in the stroma. This distance is like 20, 30 microns. I mean, it's really close, but they're not sitting right on top of the cancer cell. That's a point that is going to come back recurrent a few times as we talk about this. So overall, mouse model suggests that the tumors are immune deserts. Human studies show that they're really much more abundant like the ocean. There's a lot of stuff going on in there. Initial results from clinical trials have been disappointing, and there's, again, more things in there. Most of the trials are patients with liver metastases that turn out to be a little more like an immune desert. And we wondered if we could create an experimental model to test the hypotheses in pancreatic cancer that's a little closer to, what we see in the patients. So, you guys, most of the people who've been here have heard trainees in the lab talk about the slice culture system that we use. Fundamentally, we patients kindly donate tissue. As soon as you ask them, 98% of them are say, sure, I don't need any of it. I'm like, well, no, your pathologist needs some of it, but we're going to take a piece of it with the pathologist watching us, and we're going to send it to the lab where they're going to cut these little cylinders into slices and put them into culture and do all sorts of things, treat different drugs. And then we have a lot of different readouts that we do after that. So one of the first things that we found that was really interesting, and to be fair, it was based on some work from mouse models where the mechanism wound up being slightly different, but still it worked, was that if you blocked this pathway, CXCL12 to CXCR4. So CXCL12, it's a protein made by um, the fibroblasts, and CXCR4 is a receptor on T cells and other immune cells. So if you block that pathway, you can help the immune cells find their way towards the cancer cells, right? As I mentioned, they were sitting in the stroma. We found that if you blocked PD-1 at the same time, you wind up killing the cancer really effectively in the culture system. All of these things are really to show that as you give these different combination of drugs, so this is the CXCR4 blocker, this is PD-1 antibody, and then this combination, you can see an increase in the number of immune cells. You can see gamma interferon, granzyme B, TCR clones are expanded. And then what we also found was that if you specifically look at the immune cells and the T cells under a live microscopy situation, you can watch those cells migrate. So literally within an hour, actually it's less if you really watch while it's happening, as soon as you block that pathway, these immune cells start moving towards the cancer cells. What they require to kill the cancer cells is also to have that PD-1 inhibition. So that's the brake on the T cell. That's going to prevent these activated T cells from killing a target because it's part of immune regulation to keep immune cells that are activated from just kind of killing indiscriminately. So based on that, I spent with quite a few colleagues probably the last 6.5 years trying to create a clinical trial to test this in the neoadjuvant setting. And it was 4 years going through Southwest Oncology Group of the National Clinical Trials Network to eventually get to the point of it getting turned down. We were trying to do a national study where we tested chemotherapy plus CXCR4 and a PD-1 inhibitor before surgery. And everybody thought it was a great idea, great idea, great idea, great idea. And then the final point, it got shut down. So then we started again, and we decided we'll try to do it internally. And fortunately, we were able to get funding. We were able to get philanthropy funding, a grant, and one of the companies. And this is the study that is really close to starting. We already submitted the FDA IND, and we're going to have 65 patients total resectable or borderline resectable pancreatic cancer. So that just means you can either take it out or you could take it out most likely after chemotherapy. A little bit of blood vessel involvement to start. We're randomizing it. I really wish we could flip this around because really it's a 1-to-2 where it's 1 to 2 randomization, just the numbers. We're going to have patients get Nilirifox. I mentioned FOLFIRINOX. It's really similar. It's just one of the drugs is replaced with an albuminized irinotecan. And then we're going to give them a PD-1 inhibitor in one arm and then a PD-1 inhibitor plus the CXCR4 inhibitor in another arm. So it's actually kind of a neat trial because it's almost like a scientific experiment, right? We have 3 of the groups that we can then, and what's neat about it is that it's a neoadjuvant study. We're going to be getting tissue, right? We're going to be operating on most of these patients. And one thing that's nice compared to a multi-center national trial is that all the tissue is going to be here. And we have a lot more control over what happens. So from a scientific standpoint, it's going to be really exciting to be able to see what happens to this. And I can't wait for this. This has been like a long time coming. This idea of the stroma is something that stretches across different tumor types, as I alluded to. And our lab has been studying this really rare disease called fibrolamellar cancer. It is maybe a 1 in a million kind of disease incidence. Young people, so generally adolescents or young adults get this, and they're typically people who have like a normal liver to begin with. It was lumped together with hepatocellular carcinoma for a long time, but it is really quite different from hepatocellular carcinoma. It has these like big areas of stroma and then cancer cells. So like here you can see stroma and there's the cancer cells. And when you look for the CXCL12 that I was mentioning, you can see it, again, it's like in these stromal regions. And the immune cells, the CD3 is T cells, are sitting right next to that CXCL12. So we were wondering whether similar mechanisms as we saw in pancreatic cancer might actually work in fibrolamellar cancer. Remarkably, over a fairly short time, we got a bunch of fibrolamellar cancers, and then there's been very few in the last year and a half, which was much to Jason Carter's chagrin. But fortunately, we had a lot of things that were still analyzable, and then we've had a few tumors here and there. Fundamentally, that same combination does lead to killing. And much more work has gone into kind of the understanding the biology of what's happening, which is really interesting. And we can see that when we block the AMD 3100, we can see changes that are specifically related to chemokine axis, chemotaxis. And when we block PD-1, we can see that it's all these things related to regulation of immune response. And then when you block both, you get both. So you kind of have like these separate axes, and you need to get at them at the same time to get all of the activity. So it's really important to break it down into these different areas. This is just showing really how extreme the difference is when you look at, say, CD8 T cells, for example. And if you just look at the control group down to the one that has the combination, you can see this proliferation of CD4, CD8 T cells. There's granzyme, which is one of the killer mechanisms for T cells, is all increased when you do that in the culture. So again, we are trying to move all of the things that we do. Ultimately, we're trying to get to clinical trials. So we wrote this grant, and honestly, it was Jason over like the holidays wrote this whole R01 that we submitted to do a clinical trial where we give the CXCR4 inhibitor. And in this case, based on a lot of other data from other trials and some work that's still kind of to be published, we're planning on including a PD-1 inhibitor and a CTLA-4 inhibitor. So that is hopefully coming down the pike. We're going to be looking at lots of different ways to try to get this trial funded. It's going to be a much smaller trial. We're hoping about 16 patients where we get some signal. And even though it's a really rare disease, it's a very tight community. Part of the reason we're able to do all of this work is that there's this foundation that gives a lot of funding towards fibrolamellar cancer. And we are very connected with them. And actually, we probably have more fibrolamellar cancer researchers at UW and Fred Hutch than anywhere else in the world. It's really ridiculous. And actually, one of the people who is really big in the T cell receptor side of things just moved to the Fred Hutch from St. Jude's. So our group keeps growing. I think we're going to be able to do this, but as I was mentioning, it's a tight community. So if we have a trial, patients will come here from other places also. So I think that that's likely. So I'm going to talk next back to pancreatic cancer because everybody's been reading about it in the news, and I'm sure people ask you about it. And I mentioned KRAS. I put the date up there because you can see this is like last month. All this stuff has been coming out over and over again. There is a really incredible set of new drugs that have come out recently to treat patients with KRAS-driven cancers. And I'm going to talk a little bit about KRAS. I'm not an expert in this kind of stuff, but KRAS itself is a really important molecule in like every cell. The RAS is a small GTPase that it basically is like one of the many on-off switches for cells in terms of like proliferation and downstream signaling. And if we wanted to have another lecture where I could get Ray Young to come up here and talk about all of this downstream signaling, which is truly his expertise. One of the problems in RAS mutated tumor is that you get constitutive active signaling that drives like kind of every major cellular process and has them keep going. It was really hard to target this RAS activity before, and I don't understand drug development really well, but apparently RAS is very slippery and was always difficult to target. What they eventually figured out is that for it to signal, it connects to cyclophilin A, and it becomes this complex. And the most recent drugs bind to this complex and prevent the signaling. So once it's all together, it's actually binding to it and keeping it from being able to signal. So that's as much as I'm going to get into it. Now, it's been incredible when you look at some of the data, and I'm going to show a graph. This came out 3 days ago. Like literally, I just added this because we didn't have all these data, and they're coming out right now. This is patients who have previously undergone chemotherapy for pancreatic cancer and basically were failing their chemotherapy. Now, second line pancreatic cancer treatment with an oral drug, and this is showing the control. This KRAS inhibitor daraxonrasib versus the best chemotherapy they could come up with in the second line. This is actually like unbelievable, right? Like no one's ever seen anything like this in pancreatic cancer. Tumors are shrinking, they're going down. However, most of the patients do have the tumors start to grow again. And there's a lot of biology behind mechanisms of resistance to this. So even though it's super exciting, it's not likely that it's going to be the end of everything. So there have been a bunch of mouse model studies, all the caveats there, but that are suggesting that the immune cell response, especially the T cell response, is critical for these RAS inhibitors to work. What you're seeing on these graphs is if you have the vehicle and isotype, so this is just control, this is the mouse survival, and they basically die very quickly. If you give a CD4, CD8 antibody, they die really quickly. If you give the daraxonrasib, which is the KRAS inhibitor, you see an improvement. If you give either anti-CD8 antibody or a combination of CD4 and CD8, you see kind of in between. So to get the full effect, you do need some of the immune response. And then in this one, basically, it's just showing that if you add a PD-1 inhibitor to the daraxonrasib, you get better survival for the mice. So combining with immunotherapy does seem to make sense. So we, a few months ago, started testing this in culture. And we did the slice cultures, and what we're showing here is just kind of a bunch of fluorescent images of the like 60 protein assay that we did of the tissue after we took it out. And the important things that I think are worth taking out of this is that in the end, the number of immune cells and just cells in general really wasn't that different between the controlled treated groups and the daraxonrasib treated groups, regardless of like which immune cell population on a global end you look at. But if you start comparing like cytotoxic to exhausted T cells, the daraxonrasib actually increased the number of like cytotoxic T cells. And then similarly, the inflammatory macrophages versus the immunosuppressive, and I'll put quotes because there's a lot of controversy on what you define as
Picture
what.
many times.
The inflammatory ones were increased with
Wow,
the
I feel
daraxonrasib
terrible.
treatment.
You are busy.
And
We tend
getting
not
back
to
to our
assume that you
story
know
of
anything
the
outside of
stromal
patient care
exclusion,
has
immune
you.
exclusion,
I'm gonna have to
where
go
the
watch the
cells are
recording, and
sitting,
then that way I can
this
text
was
him
really
about it and be
striking
like,
is
I
that
loved that part when you said
we just, I
that.
mean, all of these are kind of similar. It's just breaking down like
I
all
don't have
CD18
really
cells versus
anything
exhausted
specific
or
to
cytotoxic.
like. I
Same
think I'm
story
gonna be
across all of
okay.
them. If you, the
I'll post
slices
it
where the
afterwards.
daraxonrasib was put on the culture,
Doctors covering
there was
cough.
more immune exclusion. The T cells were further from the cancer cells. And as we looked into it more, it looks like fibroblasts, when they're treated with this drug, make more of the CXCL12 that leads to that connection between the T cells and that stromal region. When we treat it with daraxonrasib or plus an anti-PD-1 drug or a combination of the anti-PD-1 and then the CXCR4, CXCL12 blocking drug, this is now, as we go down here, these are the T cells are getting closer to the cancer cells. So we're able to kind of fix that problem. And when we look at killing, we can see that when we add any of these drugs, we can see more killing. So we're kind of imagining our next trial. And Sheila Damle, who was a postdoc in the lab and as of 2 months ago is now a medical oncology GI faculty at Fred Hutch. But she's still doing her lab work with us, so proves that we have a nice environment. She submitted a proposal to the Lustgarten Foundation to try to get a trial where we treat with daraxonrasib or a combination of that with the CXCR4 inhibitor early. This is called a window of opportunity trial, really short course treatment, and then do surgery. It may help people. We're going to learn a lot of biology in that. So we're hoping that we'll be able to do that. That's going to be really exciting. So let's reimagine this patient's story, right? We did neoadjuvant KRAS inhibitor, CXCR4, and PD-1 inhibition. Uneventful Whipple, no leak, because he got preoperative dose of lanreotide, and then had great outcome. Cancer didn't come back, and apparently I didn't know this. I'm not really a big Simpsons fan, but it was just fit. He has a birthday, which was literally that date, and if you look it up, that is his birthday. So his 70th birthday just happened. So he made it. So this is part of the team. I really appreciate kind of everyone. I'm not going to get into it. Sadly, Kristen has done an amazing job in the last 2 years in the lab, but her stuff just didn't fit well. It was colorectal cancer, and I couldn't squeeze it in, and we didn't have time because you'd kill me if it went over. And I appreciate the department support, Dr. Pellegrini, who hired me, and Dr. Wood, who keeps re-employing me. So I really appreciate the support, and we've gotten a bunch of funding, and we have an amazing lab team, and this is not everybody, but it's a good proportion of them. So thank you.
You have a question? Amazing work, Dr. Pillarisetty. It's nice to kind of get it back from 30,000 feet. I was wondering if you could talk, you looked a little bit at the very end, you mentioned at the very end, talk about your approach to mentorship, talk about your approach to trainees coming in the lab. I'm sure you don't say yes to every single resident that comes knocking on your door and kind of how you envision fitting the right project for the right trainee or faculty, medical student, et cetera.
Sure. Oh yeah, thanks. Great question, Dr. Sham. I actually do say yes to every resident who knocks on my door. And I think that's the key to mentorship is to think about what that person needs and then ideally come to some intersection with what you do. And I don't say no to anyone, but I have told people I don't think I'm the right person, right? And I'll direct them to the right person. But I always think that yeah, the key is you have to think about that other person. Like, where are they going with their career? You have to know about them, right? You have to ask questions. You can't just assume that you're going to slot everyone in like it's Tetris, right? You just can't do that. You can if your only goal is to get ahead in the short term. But I think if you're trying to build something bigger, you're trying to build a culture, a community, then you have to work with where people are, you know, intrinsic motivation, right? What is driving them? What do they want to accomplish? I think that's really the key. And obviously, you want to attract great people, but I think most people who get to this point are pretty good. So usually, if they don't do well, it's probably an environment thing at that point.
Dr. Pillarisetty, this was a master class in being a surgeon scientist. I mean, it's so impressive. And I like the way that you made it 25 years and not a quarter century. I understand the reasons why. Um, and I hope this is, I'm sure it's an inspiration to our other faculty and residents that see what is possible. But within that is an enormous amount of tenacity and persistence and disappointment. And so how do you manage the failures along the way to kind of dust yourself off? A grant was rejected, a trial didn't turn out the way you expected, and yet you keep making this progress and having new ideas that are making a difference, that are making progress over time.
Thanks for that question, Doug. I was actually going to have a list of the grants I didn't get, but that would have taken too long too. It was, I mean, honestly, like I still haven't gotten an R01, which supposedly is the arbiter of your successful scientist at this point. So I guess I feel like that's why I say trying, right? Timing plays into that. Mentorship plays into that. I mean, when I started, I had a lot of problems with the first lab I went into. I didn't talk as much about the fact that I stopped doing mouse model work because the lab I went into was with somebody I could not work with, and other people have had problems with that same person. And I had to pivot and do something completely different. All of my research as a trainee was mouse models and mouse immunology, and I had to completely shift 6 months into my time on faculty. So I think you have you have to believe people when they tell you that there are a lot of hurdles, and I think it's really hard when you're the person going through it. You think, oh, I'm the only one who's going through this terrible stuff, when in fact most people who have done something different have had a lot of hurdles to do it. There are obviously people who come into a good environment. There's nothing wrong with that. It's great if you get set up in a great environment and things work from the beginning, but there are a lot of times that it just doesn't work. And I think you just have to have a really strong vision of why you're doing it.
Echo the fantastic work that you're displaying here and you've been doing. It's really hard, as you said, and there's only so many hours, waking hours in the week. Can you talk a little bit about surgeon as a collaborator? Because you need to be spending a few days a week in the operating room and doing that sort of thing. So there's a limited amount of time, and so you've done a good job of putting together teams and making connections. Because I think you recognize probably that you can't do all the work that it takes to make these projects go forward.
Yeah, no, thanks, Dr. Olshaker. That was, critical to a lot of the work was just meeting people, finding alignments, finding areas where other people are interested in what you're doing. I think for everybody, there's a certain level of what they would want to do. I would say that everyone here at some point loved science, right? I mean, we all went into medicine. And I think most people would be really interested in being involved in it one way or the other. And there's a continuum of like how far along that pathway do you want to be involved, right? Do you want to be running your own lab and have collaborators, but it's like mostly your project and then you help them with their projects? Or do you want to be, um, the person who has the connection to the patients and goes to some lab meetings where you're now part of that group and you're helping drive it? I mean, all of these are really important, and it winds up being an individual, like kind of motivation and interest, and then time, right? If you're lucky enough, some people would say lucky or not, but lucky enough to have some um, dedicated time for research, then that's great. But the thing to know is that if you're a surgeon, it depends on what kind of surgery you do. If you happen to start out as a pancreas surgeon and even if you're a relatively low volume, you're going to be getting called about patients who have problems. And the problem is when you start out, you're going to have even more problems. So you're going to have even less time. I mean, honestly, I have more time now, even if I'm doing more than I did 16 years ago, just because I can turn my brain off of my patients immediately, right? I can go see them. The residents will know that I don't see them that often because I tell them in clinic, I'm like, if you're doing well, you're not going to see me. And they're like, oh, I hope I don't see you. So, but when I started for like 5 years, I don't think there was a day that I didn't round if I had a patient in the hospital. Like I was in the, like my wife would be sitting in the garage, parking garage with my kid asleep while I was rounding on like Saturdays and Sundays, right? I would do a case and then I couldn't write the grant because I kept looking at the medical record to figure out what's going on. So you have to know where you are and what you do. Don't necessarily go into pancreatic surgery. That would be like number one thing. But yeah, collaborators are key. And there are a lot of people. I mean, like everybody wants their clinical collaborator. Like the scientists, they really want clinical collaborators because they want grants. All they want is grants, right? So yes.
I don't have that much more to add, but I mean, for those of you in the audience thinking about the subject of this talk, which is being a surgeon scientist, you have seen an outstanding example. That said, for decades now, we've been told that the surgeon scientist is a dying breed. And statistically, that is true. If you look at the number of NIH-funded surgeons, is dwindling. And the forecast doesn't look very good either. Uh, so the question I have for you, Venu, is, I mean, obviously you have the right construct in your mind to become a surgeon scientist, right? So what do you think would be necessary to promote that in an environment like this?
I think, and thanks for the question, Dr. Young. It's a great, thoughtful question, of course. And it relates to finding people like where they are and what they're interested in doing. And when you have people who really want to be surgeon scientists or want to try to be a surgeon scientist, as we've been trying to do, the support I think needs to be pretty broad. It's in terms of time and mentorship and money, but I would put it in kind of that order. I mean, a lot of times money gets put at the top. I would put kind of money at the bottom. I would put mentorship at the top and time in the middle. Because a lot of times people say, if only I had $1 million, I could do this. I guarantee that if you give most people $1 million, they're not going to accomplish jack. I mean, like nothing's going to happen. Most of the time it's, you know, having somebody help guide you, having really good ideas. And then you need the money to be able to make it happen. But if somebody had given me $1 million my first couple of years, I don't think I would have gotten that much done with it. I'll take it now.